glad to have Professor Sten Vermund, the former Dean of Yale School of Public Health, Anna Lauder Professor of Yale School of Public Health, a global expert. He's with us today. He just landed this morning and he's going to deliver 2 back-to-back lectures, Implementation Science and HIV Research Cascade, and Implementation Science and Non-Communicable Diseases. Prof, can I just request you, if you can finish your lectures at 12 or 12:05 or 10.
Sure.
Thank you very much.
We'll be efficient. So I've had quite a journey to get here. I don't want to waste time telling you all the adventures, but suffice it to say that my flight from JFK to Singapore departed 21.5 hours late, almost a complete day. And then even coming from Singapore to Kuala Lumpur, there were birds on the runway. So they had to shoot up again and take another turn around and land on a different runway. So I've had quite the adventure, but I'm so glad to be here and to talk to you about implementation science for HIV and NCDs related to HIV. So there'll be 3 parts to my talk. Very quickly, UNAIDS estimates from their most recent years, 2021 and 2022, and then 2 other topics. So you can see that the number of people living with HIV is actually going up every year. So you remember that prevalence is a function of incidence times duration. Now, if I tell you that incidence is dropping around the world, then how can prevalence be going up? Because duration is going up, people are living longer, thank God. But we are having more people with HIV, not fewer, because people are living longer. You can see new HIV infections are dropping. There's one exception, and that's Eastern Europe and Central Asia. That's the only part of the world where rates are going up still. So places like Kazakhstan, Russia, etc. The rest of the world, we're seeing declines. And deaths due to AIDS are dropping because of expanded access to antiretroviral therapy. Now, when you look at global HIV prevalence, it's not a very useful concept because we know that it differs wildly by different regions and different subpopulations. But just FYI, for your information, 0.7% is the global estimate. So somewhere in the neighborhood of 1 in 150 people is HIV, living with HIV. However, it's 2.5% among sex workers, 7.5% among men who have sex with men, over 10% in transgender persons, about 5% in people who inject drugs, and about 1.5% in persons in prison. Now, a key demographic, especially in Africa, is adolescent girls and young women. 4,000 adolescent girls and young women ages 15 to 24 became infected with HIV every single week in 2022, and it hasn't changed much since then. So 78% of all those women are in sub-Saharan Africa. Prevalence has exceeded more than 40% among women of childbearing age who are around the age of 30, who are living in parts of KwaZulu-Natal in the southern part of South Africa, where Durban is the capital. So that's perhaps the most intense epidemic in the entire world. But can you imagine if you're a midwife or an OBGYN or a pediatrician and 40% of your 30-year-olds who are delivering in your service are HIV infected? Tremendous burden. But only 42% of districts with high HIV incidence in sub-Saharan Africa had dedicated HIV prevention programs for adolescent girls and young women in 2021. Children are not escaping this disease. You can see that the number of children living with HIV is dropping because of success in prevention of other child transmission. What WHO and UNAIDS now call elimination of mother-child transmission. New infections are dropping, deaths are dropping with access to antiretroviral therapy. But I hope you're suitably horrified that we still have 1.5 million children living with HIV and still have well over 100,000 per year, even though we know how to prevent it. This is the field of implementation science. How do we deploy what we know how to do? Now, in 2023, the UNAIDS report said that nearly 30 million of the 39 million people living with HIV globally are receiving treatment. Well, that's a lot of people. That's, you know, a hefty chunk of the total, but it's not everybody, and we're still short 10 million people who are not receiving treatment. And we've gotten about 1.6 million new persons on treatment in each of the 3 years, 2020, 2021, and 2022. So we are still adding people to the roles of antiretroviral-based care. And of course, the whole point of this lecture is that people are living longer with HIV, and what are we going to do about it? So if you look at that from UNAIDS, HIV treatment is estimated to have averted 21 million AIDS-related deaths between 1996 and 2022. So that's a huge achievement. And there are people in this room who can take partial credit for the lives you've saved here in Malaysia. Now, with declining death rates, persons living with HIV are living longer. More are dying from NCDs than are dying from HIV-related diseases. That's the estimate. More HIV-infected persons are dying of NCDs than of HIV itself. That's the current estimate. And you can see AIDS-related deaths dropping, and you can also see, I guess I don't know if I can point with this. Well, you can see that little red dot out at 2025. That's where we're trying to get to. It doesn't look like we'll get there, but we may come close. So after that quick introduction on global statistics, let's talk about emerging NCDs. And sure enough, this got a little garbled in the translation from one computer to another, but you can see cancer, diabetes, cardiovascular disease, chronic respiratory diseases, and other NCDs. And what contributes to NCDs? Physical inactivity, obesity, tobacco use, unhealthy diets, harmful use of alcohol, malnutrition. Those are preventable causes. There are a lot of causes that are not preventable, like old age. I mean, at some point we die of something, and we die of heart disease, cancer, whatever it is, and that may not be associated with the conditions that I list below. So here are age-adjusted prevalence of obesity and diagnosed diabetes among U.S. adults. And you can see in the United States, we used to have no state in 1994 that had greater than 18% prevalence of obesity, and no state that had greater than 6% prevalence of diabetes. But now, most states have greater than 26% prevalence of obesity, and more than half the states have more than 9%. So this is in a very short period of time. This is only 20 years, all right? So we really have a very serious crisis in the United States combining poor diet and sedentary lifestyle. Now these are the non-communicable diseases in a 4x4 table that WHO has provided. And you can see tobacco use tick marks all of the boxes. It increases cardiovascular risk, diabetes risk, cancer risk, and chronic respiratory risk. Unhealthy diets, at least 3 of the boxes, cardiovascular, diabetes, and cancer, and physical inactivity, all 3, and harmful use of alcohol, all 3 conditions. Now, some of you say, well, how can alcohol cause cancer? Believe it or not, there are multiple cancers with strong associations with alcohol use, with physical inactivity. No time to talk about the details because I'm here so late. So global obesity is growing, maybe not quite as fast as in the United States, but at shocking rates. We have 1.6 billion adults overweight in 2005. 11 years later, 2.3 billion adults. So it's just an inexorable rise, and the number of obese adults is now double what it was in 2005. And we even have millions and millions of children under the age of 5 who are overweight, and many are obese. So if you look at, for example, obesity and diabetes in the country of India, the largest population country in the world, you see a parallel to the United States. Not as dramatic, but the trends are in the same disturbing direction. So let's look at total deaths around the world. 58 million per year die. The deaths from non-communicable diseases are 35 million of the 58 million. And the deaths from non-communicable diseases in developing countries, low and middle income countries, is 28 million. So that is about half of the world's total. And then the deaths from NCDs in low and middle income countries that could have been prevented based on preventable and remediable risk factors is estimated at 14 million out of the 28 million. So half of all the deaths are seen to be preventable in low and middle income countries, and representing a huge proportion. So we have to play catch up. Now this is a busy slide. I just want you to glance at Africa, where the deaths from NCDs, the proportion is going up at a very fast rate, faster than anywhere else. So with control of infectious diseases having improved considerably, malaria, TB, HIV, to name 3, neglected tropical diseases, to name a 4th category. The proportion of deaths from NCDs is going up. People are living longer in Africa. But take a look at the absolute numbers of deaths. It's here in the Western Pacific where the absolute numbers are so impressive. 105 million NCD deaths in the Western Pacific, representing more than a quarter of all global deaths. Now, what is the socioeconomic impact of NCDs? Well, you have macroeconomic impact. The World Economic Forum estimates high negative economic impact from NCDs. Heart disease, stroke, and diabetes alone are estimated to reduce between 1% and 5% of GDP in LMICs. So maybe we should be investing to prevent this, and maybe it'll pay off in terms of improved GDP. Now, the impact at the household level, I don't have to explain to you. The World Land Bank estimates that 1/3 of people living on just $1 to $2 US per person per day, so the lowest 20% on planet Earth, die prematurely of NCDs, often in their most productive years. So what does that do? That leaves a widow, that leaves orphans. And if it's a man, or if it's in a woman, the mother as well. So low-cost households suffer the costs, long-term treatment and unhealthy behaviors. The cost of caring for a family member with diabetes can be 23% of the entire income of a low-income household. The poorest households spend more than 10% of their income on tobacco. And cost of essential drugs to treat and cure cancer makes them unaffordable to most of the poor. So these are all things that implementation science can address. Now, just a sidebar, these are 2 of my former trainees, and they were 2 of my most talented former trainees. Dr. Saeed Abdul Mujib is from Pakistan, an immensely talented individual who did his master's degree with us and went right back home, back to work. He came out of his office one day, got into his car, slumped over his wheel, dead of a sudden cardiac event at age 49. Dr. Moses Sinkala, everything that I'm going to tell you about Zambia is thanks to Dr. Sinkala. Every shred of the work was thanks to his advocacy, his insights, his wisdom. He was one of the first 2 Zambians that I trained at the University of Alabama in Birmingham when I was there. He was 51 years old when he got some money out of a cash machine when he and his wife were on holiday, and he collapsed and died. And so I'm guessing that these 2 young doctors did not have the kind of preventive cardiology advice that I have. So my father had familial hypertension at age 40. Guess when I was diagnosed with hypertension? Yes, age 40. Now, like any self-respecting physician, I ignored it for 8 years, but then by age 48, I was on 3 drugs to control my hypertension. My doctor said, I never need 3 drugs to control hypertension, but yours is very hard to control. So you're going to be on a calcium channel blocker and an ACE inhibitor and a diuretic, because every time we take you off one of them, you spike again. So it doesn't make sense biologically, but you need 3 drugs. And subsequently, I've gone on a statin and on a prostate drug. I take 6 pills every morning. Now, I'm not sick from any of these diseases. This is all preventive medicine, right? But in so many low and middle income countries, even the middle class and upper middle class is not getting the kind of preventive attention that I'm getting. And everything that I'm taking every morning, 6 pills, is prophylaxis. It's all preventive. For my cholesterol, for my hypertension, for my prostate. So maybe too much information. But I thought it was important that you see that we're losing young people. Immensely talented. Both of them had their MBBS, both of them had their MPH, both of them passed at about 50 years of age. Now, you'll see this, I'm not going to spend any time on this, but when you go to the Institute for Health Metrics and Evaluation at the University of Washington, they've estimated the percentage of adult population who are obese. And I hope you'll be surprised when you see countries like Norway, Sweden, Finland, Russia, Poland, France, England, all in the 1/4 range. So even these countries where we have the stereotype of fit, lean people, no. Obesity is surging in these countries as well. And when you look at Kuwait, 40%. Guam, 42%. Some of the southern Pacific island nations with astronomical obesity rates. And even creeping up in countries like Bangladesh. So this I found really interesting. In preparing for this lecture, I found this paper. These are trends in major non-communicable diseases and related risk factors in China from 2002 to 2019, from interesting survey data that looked pretty good to me. So if you look here, you see the rise in obesity, and you see the consistency across age group in the upper right. You see urban and rural consistency in the lower left. And then you see men, the cross-tabulation between urban men, urban women, rural men, rural women. There's no exceptions. They're all going up. This is China. Hypertension on the rise. And those dotted lines are the targets that the Chinese government has set to try to reverse the trend. But the solid lines are on the rise for men and women and overall. Same thing with age group, same thing with urban rural, same thing with the cross-tabulated folks. There's diabetes on the way up. Men, women, no matter what your age, no matter urban or rural. So think about a country like India. With the vastness of the population pyramid. Take a look at the population pyramid in 2001 compared to 2016. Take a look at the proportion of persons over the age of 60. It's an impressive rise. So we're going to be facing this in Malaysia, just like in India. And there are plenty of people who are overweight and obese in Malaysia. Now, when you look at projected deaths by cause and income from 2004 projected to 2030, you see that in low-income countries, the proportion of cardiovascular disease and cancer is going up, even though the absolute numbers of deaths are not. So as NCDs are surging, communicable diseases are declining. Let's take middle income, pretty much the same story, and high income, where you have a continued burden of non-communicable diseases. Now, what about school children? Djibouti, 12%, Egypt, 21%, Jordan, 17%, Lebanon, 18%, Libya, 22%, the UAE, 33%. That's a lot of children who are overweight. Now, non-communicable diseases, tobacco is a risk factor for 6 of the 8 leading causes of death. And you can take a look there of the dark bars is where the proportion, the hatched bars is where the proportion of tobacco-related disease is, and you add it all up to the right, and you're talking about 5.5 million deaths per year. And where do you think the cigarette companies are selling their products now that use has dropped in places like the US and Europe? They're trying very hard to sell it here, China, India. And that's the proportion, the share of cigarette production and consumption in developing countries between 1970 and 2010. And the poorest people smoke the most. This is a paper from Bangladesh, where the highest use is in persons who are illiterate, who have lowest income, and who are landless. That's the further left of each of those. And if you look at cancer in developing countries, you see South Africa set to see a 78% increase in cancer incidence by 2030, which is astronomical. Only 16% have adequate medical care for cancer in South Africa, 84% making use of the public sector for all their care, and treatment costs are just too much for most people with cancer in South Africa. And the financial knock-on effects also has far-reaching social effects. Now look what I found preparing for this lecture. This is your poster that I found from 2020, and then I said, I wonder if they published it. Sure enough, there it was, published in 2020. And this is a study of 330 participants who were followed with complete laboratory and pharmacy records for NCD management. Maybe Dr. Raj Surya and Dr. Lee are in the audience. Yes, where are you? Maybe? No? Anyway, they found among HIV-infected persons that you had considerable risk of diabetes, hyperlipidemia, hypertension, and they created a cascade to try to see how well they were doing in achieving target labs, and it wasn't as good as they wanted to, as you can see on the far right. And similarly with HIV management, it seemed that they were doing even better than with NCD management, using the same kind of proportionality of the cascade of care. And diabetes was reported 13% of the HIV-infected persons in this study, dyslipidemia in 88%. 88% had dyslipidemia. I found that remarkable, really. And hypertension, 44%. So they also looked at mental health conditions, which I thought was very impressive. And of the proportion who were diagnosed with mental health conditions, 83% of them were diagnosed through this research project, not through prior knowledge. And only 17% had received referral to psychiatry, and 83% of the people who had been referred went for psychiatric services. The prevalent symptoms of depression, anxiety, or stress were noted in 23% of everybody. Now I'm going to close this lecture with a case study from my own work. I apologize for those of you who may have heard this last year. So this is scaling up cervical cancer programs within HIV programs in Zambia and in India. So keep in mind that HIV/AIDS, with about 4,000 people per day being infected, current trends, 1.2 million new HIV infected by 2025. Seems like we're somewhere near there now. And access to ART is improving. So imagine a woman who never gets screened for cervical cancer, got HIV from her husband, which is how many women, most women, get HIV, and they are not being screened for cervical cancer. So is it plausible that this husband, who may have outside partners, that's how he got HIV, also is passing on HPV? And the answer is yes, it's plausible. So we don't want women to live with antiretroviral therapy just to die of cervical cancer. That makes no sense. It doesn't make sense for people to be dying of NCDs if we can screen and treat. And of course, cervical cancer is also highly prevalent, with 600,000 new cases estimated by WHO in 2020 and 340,000 deaths. And of the deaths, 90% are in low and middle income countries. Why? Because the high income countries screen and treat aggressively. That's why. Now, this is kind of introducing implementation science, the concept of system failures that lead to cervical cancer diagnoses. Maybe a woman doesn't come in for screening, or maybe screening is not available. Maybe they come in, but the healthcare workers overlook screening and don't do it. Maybe the colposcopy for an abnormal screen is not done, the follow-up is not effective. Maybe they diagnose the precancerous lesion, but they don't actually treat it. And then the patient gets cervical cancer. So we know the cause, we know how to prevent it, we know the target populations, we know the program needs. What we don't know is how to scale it up given resource constraints. Does that sound like an implementation science challenge? Yes. And how do we integrate fully with existing health systems? Do we integrate with HIV clinical services? How much community engagement are we going to need to succeed? So this was our very first paper a long time ago. And all we did was invited 150 HIV-infected women in Zambia to get a pap smear. And do you know how many of the women, when we explained to them why we were doing it, how many of the women refused? 0. Not a single one, even though most of the women were not familiar with the concept of pelvic exam, other than in childbirth. But when they heard what we were intending, 100% of them agreed to be screened. But these data were shocking because 19% of them already had suggestive lesions of cancer, and 34% of them had high-grade squamous intraepithelial lesions. So in Zambia, more than half of the women were likely destined to get cervical cancer if we didn't screen and treat them. So this was tremendous. Now with PEPFAR resources, the U.S. President's Emergency Plan for AIDS Relief, we were able to talk CDC into letting us screen for cervical cancer as part of our program, and we were able to massively increase the surveillance through screening. And we offered it nested within HIV clinics, but any woman who wanted it could get it. So you could see the HIV positive women were in the red, the unknown status were in the blue, and the HIV negative women were in the green. So we were able to surge our program in all three. And remember, visual inspection with acetic acid is a lot simpler than pap smear. I think we have the pap smear capabilities in Malaysia, but in Zambia, we didn't have cytopathologists, we didn't have pathologists, so visual inspection with acetic acid of course 5%, is just vinegar. So you paint it, you wait a minute, you have a high intensity bulb, you take a photograph with a high pixel photography, and it pops it up on the computer screen so the nurse can see the lesion. It's sort of the poor person's colposcopy. It's almost like colposcopy, but much simpler and much cheaper. And then we could use those cervicography images for quality improvement. And every Friday afternoon, we had the quality improvement rounds. And within a year, these nurses became better at inspecting the cervix and diagnosing it than any physician that I knew, because they just became very expert at it. And there was a clinical trial in India that used VIA in an actual clinical trial. And they found RCT evidence of lower incidence rates of cervical cancer in the screened women using VIA. And that's all you need. Bottles of vinegar, some cotton swabs. We did a comparative study in India, and after training the nurses very carefully, that's the key with VIA. You have to train people very carefully. We got better results with sensitivity and specificity for both CIN2 and also CIN2 with carcinogenic HPV. We got better results than with cytology, regardless of what cutoff we used. So it is possible to use these lower technology schemes if you're working in, say, Cambodia, where they may not have cytopathology available in rural areas. Here, I think you can use cytopathology. And then we established a cervical cancer prevention program nationwide. It was a public sector and academic partnership with all of these, I won't read this, but all of these different participating entities, hospitals, ministries, schools of medicine, schools of public health, and an NGO. And we got the attention of the George W. Bush Presidential Center. They took an interest in our work, and with the Susan Komen for the Cure NGO, and with other partners, we were able to launch the Pink Ribbon, Red Ribbon campaign to screen HIV-infected women both for cervical cancer and for breast cancer. And this became an international effort. Now, how can implementation science accelerate infectious disease discovery to practice or chronic disease discovery to practice? We want a societal impact, but Zoe Morris, in her classic study over 10 years ago now, said that it takes 17 years from efficacy to implementation. So we find out something works, and then it takes us an ungodly long amount of time to actually deploy it. And that's what implementation science is all about. How can we deploy what we know efficiently, effectively, and rapidly? And that's a science in and of itself that we call implementation science. This is an interesting slide that I saw recently. And they sort of say the elapsed time on the bottom, the innovation process on the y-axis, and they're talking about discovery, phase 1, 2, 3 clinical trials, post-launch research, synthesis and effectiveness and safety, such as a systematic review, and then regulatory approval, national policy development, reimbursement and financial support worked out, and clinical practice, public health practice, actually using the innovation. So that's one way to think about it. So, conclusion. Implementation science to improve programs is essential. Our HIV care services must screen, diagnose, and treat NCIs, NCDs. It's not that hard. It's not that hard to assess somebody's blood sugar. It's not that hard to take their blood pressure. It's not that hard to screen them for cervical cancer. Some very low intensity techniques can substantially assist HIV infected persons. So I said tomorrow because I thought I was here yesterday giving this talk, but right away we will discuss how care cascades can help us. So that's the first, and now I need to get into the second talk. I guess I can take a question or two. Yes, Dr. Spiegel.
I'm wondering if you could say more about, like, do you feel it's actually a part of national policy and is being implemented everywhere? And then would it be possible to do say cervical cancer deaths, cervical cancer incidents, and so forth.
Yes, so the question is whether these programs will survive funding cuts. Are they sustainable? Because we all know that the PEPFAR money has substantially subsidized HIV care in Africa and elsewhere. And if that goes away, or is substantially diminished, will the programs go away? At the present time, the Zambian government is so proud of this program and has taken such ownership of it. We even have people coming in from all over the world to Zambia to study the program and to evaluate how they can train their cadre of nurse and even lower level workers to do something similar in their country. I think we've had folks come from 30 countries now, including Asian countries. And so it would strike me as difficult for the Zambian government to turn its back on this existing screening infrastructure, which is a model for all of Africa. I wouldn't have said this 10 years ago. I think 10 years ago it was highly vulnerable, and if costs had, if support had been cut off, I think we would have been in trouble. Now, this will be a great challenge for you and your group, Donna, because as we have expanded screening, we've also found many more cases. So as you improve screening and surveillance, you have the paradox of cancer cases rising. So we will take some clever methodology to tease out the time discontinuity analysis, given the fact that you're actually increasing the number of cancers that you're discovering as your program is expanding. So that's the tricky part. But that's why you have your center, to tease out these tricky methodologic challenges. All right, so let's dive in. This is a care cascade oriented talk. So we've talked about NCDs. Now let's talk a little bit about the HIV treatment cascade, and I alluded to the work that you all did here in Malaysia and published a couple of years ago on the NCD cascade. And how can implementation science influence this cascade? So there are two topics. One is treatment as prevention. That means that you try to get as many infected people identified, linked to care, and suppressed so that they benefit for their own health, right? A clinical rationale. But so they don't infect their loved ones, their sexual partners, or needle-sharing partners, that they don't infect others. And that's the charitable side of it. That's the public health side of it. So doing the right thing for people, getting them diagnosed and treated, and helping them stay on their treatment is also the smart move for public health. We call that treatment as prevention. But the question was, is this realistic? Can we achieve this? So let's dive into that question. So you all know the HIV/AIDS targets for 2025 were 90-90-90, and then they were modified for 2030, 95-95-95. 95% of people living with HIV know their status. So only fewer than 5% of folks do not know their status. 95% of those people who know their status are linked to care. So only 5% fall between the cracks. And then 95% of the people in care are suppressing their virus load. So that we have success at the screening, the linkage, and the treatment success levels. So can we achieve high enough testing, linkage to care, and viral suppression to reduce community HIV transmission? That was the question being posed by these treatment as prevention studies. Can we do this well enough to actually reduce community incidence? And nobody knew the answer to that question, whether we could do it well enough. So there was the TASP study in South Africa, the HPTN study in South Africa and Zambia, and 2 others that I'll tell you about in a moment. So in some ways, this is an old concept because we were trying to find pregnant women who were HIV infected, treat them to prevent transmission to their babies. So it was the concept of treating person A to protect person B. And this is a different expression of that concept. Treat person A to protect person B, but not through perinatal transmission, through sexual or needle transmission. And we found that lower viral load in an infected partner correlated with far lower transmission to sexual partners. 2 large studies, Quinn et al. And Fideli et al. So this was our study, Fideli et al. In Susan Allen's group. And we didn't see any transmissions at less than 3,000 viral copies per milliliter. We didn't see a single transmission in several hundred Zambian discordant couples. This is the pre-treatment era. So the logic is try to treat people so they have a low viral load that they won't transmit to others. This was also seen at a community level by Tanzer when he did studies in KwaZulu-Natal, very intense transmission zone of the world, and the proportion receiving ART, the higher that proportion, the lower the adjusted hazard ratio for HIV was in that community. The Chinese took a look at this, and they had a very large database. The infected partner not on ART, the incidence rate was twice as high as the infected partner on ART in terms of transmission to, in this case, the spouse. Typically it was male to female to the spouse. And so when you adjusted for all the confounders, they suggested a 26% relative reduction in HIV transmission. Then came the definitive study, a clinical trial, HPTN-052, where stable heterosexual couples in the Americas, in Africa and Asia, were recruited. And this is the era where we were waiting for people to drop below 200 or 250 CD4 cells before we would treat them. So the concept was, well, what if we treat them very early? What if we treat them when they hit a threshold of 550? Can we actually drop transmission? So it was a randomized trial to the standard of care in the country, which was less than 250, or early ART. And it was a large study, 1,763 couples. And the results were very dramatic. 69% relative reduction in the early ART arm. But when you looked at genetically linked viruses, so you knew that that virus came from typically the husband and not from another partner, it was actually 93% relative reduction. So that really motivated these 4 studies. The ARNS is the AIDS program in France. One was called SEARCH, one was called Botswana Collaborative Project, and then the HPTN, HIV Prevention Trials Network. So the ARNS TASP study was published in International Journal of International AIDS Society in 2018, and this was the context, that little girl had an 80% lifetime risk of acquiring HIV in KwaZulu-Natal. That was the sense of desperation to do this kind of work. They identified homesteads, they visited every 6 months, they had a household assets questionnaire, individual questionnaire, dried blood spot sample, rapid HIV test, and a card that identified them as treatment as prevention subjects. If they were HIV positive, they were referred to clinics. Now you can see this clinic is actually an adapted cargo, what are they called? Container, like you have on the ships coming into Singapore. You know, the cargo. They would make a clinic out of this cargo container. So they put these within 45-minute walk of every single individual who was recruited to the study. So they dotted the landscape with these ART clinics to make it extremely easy for people to use the clinic. But it didn't work. The intervention versus control was not significant. The trend was not dramatic. The incidence rates were almost the same. So treating aggressively the HIV positive persons did not seem to reduce community load. So they asked the question, why? And this is why. At the time of the study, the UNH targets were 90-90-90, and that would be 73% of all positives would be suppressed. And what they found in the task, in both the control arm and the intervention arm, they failed to link people to care. There was so much stigma and fear that they didn't achieve sort of the community partnerships that we'll talk a little bit of. I have a short talk tomorrow about these community partnerships. And they did pretty well in suppressing them in both arms, but they did not succeed at linking them to care. So we don't really think of this as a negative trial. All it is saying we did not achieve the inputs. To call this a negative trial would be like saying your pneumonia cases didn't do very well because they didn't go to the doctor. It simply reflects that the teams did not succeed in linking people to care at a high enough level to come anywhere near the UNAIDS targets. So they were achieving 40%, and that's not good. The second study is a search study, Sustainable East Africa Research and Community Health. And to the credit of the Ugandans and Kenyans and the UCSF and UC Berkeley folks, people like Diane Havler, who did this work, they actually integrated HIV services with TB and hypertension services. They were actually wanting to start the ball rolling with NCD screening. It was a huge study, 150,000 people, 32 communities, up to 10,000 persons each, published in the New England Journal about 5 years ago. And here's what the results were in rolling out treatment as prevention in some clusters and then standard of care in others. They found a 21% decline in HIV mortality in all the clusters. The ones in which treatment as prevention was being promulgated and the ones that just had standard of care. They found 59% 3-year annual incidence drop for TB in their HIV-infected persons, which was very impressive. And they had a 26% rise in hypertension control. And they had a 32% annual HIV incidence decline within each arm, but the arms did not differ. So the question was, maybe the PEPFAR programs were working disproportionately well in the control communities so that you didn't actually have that big a difference between your intervention communities and your control communities. This is the hazard of doing community randomized trials in the context of improved services. And Professor Spiegelman can give you a whole story about the Maxart study in Swaziland, at Swatini. You got that yesterday, good. A third study was the team in Botswana working with folks at the Harvard School of Public Health, and that was also published in New England Journal. That was the Botswana Combination Prevention Project, or YATSEA in the local language. And there they did actually find a measurable difference, and about a 30% decline in community infections where the treatment as prevention program was implemented. So when you massively improved coverage, they did actually find a decline in community problems. So this was a relief. Finally, a study suggested what we thought could be possible. And then came perhaps the most comprehensive study, the HPTN-071 POPART. POPART stood for Population Effects of Antiretroviral Therapy Reduce HIV Transmission, led by Richard Hayes and Sarah Fiedler from London, with teams in Zambia and in South Africa, also published in New England Journal, also 5 years ago. So the POPART intervention was based on voluntary HIV testing by community HIV care providers. The nickname was CHIPS, and health promotion, promoting circumcision, PMT-CT, treatment and care for all persons living with HIV, sexual health and TB services, condom provision. And ART, regardless of the CD4 count, was in Arm A. Arm C was the standard of care in the Ministry of Health, supported by PEPFAR, and Arm B was the standard, was the full POPART intervention, except not the antiretroviral part, if the country had not adopted the more aggressive treating everybody. But in the middle of the study, Arm B got converted to be like Arm A, because everybody got treated because WHO recommendations after the HPTN-052 study and the Ministry of Health decisions. Even though they couldn't implement it, policy changed, and we could implement it with our research resources. So A to C was the biggest contrast, but then B to C wasn't as big a contrast as had been intended. And we had 52,000 people in this very, very large study. If in Zambia, you can see the map of Zambia in the middle there, and it was extensive all the way from Livingston on the Zimbabwean border all the way up to the Copper Belt on the Congolese border. So it was multiple different communities, highly diverse communities. It was a little more concentrated in South Africa, in the Western Cape, near Stellenbosch, Cape Town, and in that region. So there were 21 communities in total. So Arm A versus Arm C, Arm B versus Arm C, and what was found was a paradox. Arm B actually had 30% reduction, very similar to what was seen in Botswana. But Arm A had only a 7% reduction. Now these are some of the hazards of cluster randomized trials with an N of only 21. Because there were only 7 communities in Arm A, 7 in Arm B, 7 in Arm C. Now they were randomized as triplets, so that you were randomizing like with like. You were similar communities, similar community characteristics. But still, there could be a lot of differences between the communities when you're only randomizing 7. And we think that may be a big contributor. And viral suppression was, as you would expect it, higher in Arm A than Arm B, than in Arm C. Now, so why didn't we see it the way we would expect it? Now, if you merge Arms A and B, there's a statistically significant 20% reduction in incidence. But that was a post hoc analysis. That was not the research design. And we found that Arm B, just by the chance, had 38% were already on baseline versus 31% in the other arms. So it's like Arm B had a head start compared to Arms A and C. So perhaps that had something to do with it. We also speculate about the last unreached 25%. Is it plausible that a subset of people who are not being captured by the health system are disproportionately contributing to transmission? And the answer is it is plausible, because we see that in tuberculosis, we see that in STIs, we see that in a lot of public health models where the people you can reach most easily are not contributing the greatest burden to the community. The people who you have trouble reaching are contributing disproportionately. And maybe 3 years is just not long enough to follow a study like this. It took us a year just to figure out what we were doing. Then we only had a 2-year follow-up. But if viremia was minimized, the population level was seen. And this is true in all 4 of the studies I described. If you mine the data, which the investigators have done, and you pluck out the places that had the lowest viremia in those communities, you did see a community level effect reducing incidence. So that's the best we can do, and Salim Abdul Karim has framed this, the effectiveness HIV incidence and the viral load suppression. So on balance, it's favorable, saying that treatment as prevention probably works, but you have to have a great deal of fidelity in your screening, in your linkage to care, and in your suppression. If you fall flat on your face with any one of those three, you may not see the community benefit. The next topic, and then we'll send you to lunch, is implementing prevention of mother-child transmission and effective care for children living with HIV in 3 countries, Zambia, Nigeria, and Mozambique. And we were trying to address the relatively poor pediatric outcomes versus adults. All around the world, we do worse with children than we do with adults. And it's a bit of a mystery why that's the case, because we're so used to families and mothers taking very good care of their children, usually taking care of their children better than they take care of themselves. So why should we be having these bad outcomes? And that is the topic of implementation science. That's where we had to get medical anthropologists to help us sort this out. And we would find that husbands were saying, you can go to the doctor for your care, but you're not bringing my child. My child doesn't have AIDS. My child doesn't have HIV. Things like that. All sorts of community obstacles and denial. And then we had to tackle systems issues to improve care. So this is the cascade of HIV care for a pregnant woman and her infant. First of all, the woman has to have access to antenatal care, otherwise we can't screen them. She has to be in a clinic where she's offered the intervention, voluntary counseling and testing. And back then, we were using single-dose nevirapine. Obviously now we're using full-fledged ART. But in the early days, we were using single-dose nevirapine. Then the mother, the prospective mother, the pregnant woman, has to agree to the intervention and take the nevirapine home. And then she has to remember to take the pill when she goes into labor. And then the baby has to get nevirapine from the postpartum nurses in the postpartum waiting area before the mom's sent home. So there are a lot of places where this can go badly. And in 2002, we had almost no coverage because ART wasn't available. And we managed to get it up to about 30% in 2004 and 2005. By 2007, we were up to 60%, and it's over 95% today. So this was a classic implementation science challenge. We knew what to do, we weren't sure how to do it, and we weren't sure how to implement it. So there's a big body of work that took us 11 years, and I'm going to tell you about that picture tomorrow. But that picture is essentially a community mobilization, and I'll tell you about it tomorrow. So we really had tremendous success in Zambia, but we had to, let me go back just to make a point. We had to sort the challenges in every single clinic, because some clinics, we had a head nurse who, when the mother said, yes, I will be happy to take the HIV test, the nurse would say, are you sure? What's your husband going to say? What if the neighbors find out? We had nurses who were against testing in those early days. And we had to figure that out, and then we had to either get the nurses educated or transfer the nurse to a different position. And that's what Moses Galvin, he would transfer the nurses because he was the head of Lusaka Urban Health District. A woman may take the medicine and intend to take the medicine at the time of labor, but the pill isn't convenient to her when she goes into labor. She goes into labor when she's at a friend's house or her mother's house, or she goes into labor but she gave the pill to a sick uncle thinking that it would benefit him. She doesn't have the pill anymore. So then we did a whole clinical study, clinical trial of in labor dosing. So if a woman had not taken it, even if she's about to deliver in 30 minutes, can we give her the dose in labor? And that was the DRPH thesis of one of my students. And then, are there societal inhibitions where women are not going to take the medicine because they don't have family approval? And then we had some clinics where there was dysfunction in the postpartum ward, where there was a muddle in which babies were born to HIV-infected mothers, and therefore the baby wasn't getting the baby dose, because that was the dosing back in that day, a pill for the mother and a dose for the baby. We also were noticing in our Mozambique work a few years later that infant retention was really very poor through a care cascade analysis, and we had very limited early infant diagnosis in the rural area of Mozambique where we were working. Only a quarter of the babies who were born to HIV-infected mothers were being brought back for diagnosis. And only half of the mothers themselves came back, so we knew something was desperately wrong. So we deployed a quality improvement implementation science guru and a medical anthropologist to get to the bottom of this. And what happened was they did a process map. So this is what happens to women in the maternity ward in the rural part of Mozambique where we were working. This looks familiar to all of you. You know, HIV status ascertained, HIV positive, prophylaxis given, the infant is delivered, prophylaxis given to the infant, and then you tell them about the counseling and you refer them to early infant diagnosis. Then they come back a month later, they enroll the infant is examined, the PCR test determines whether the infant is infected. So this is the process map that was giving us lousy results. This was the broken system, okay? So this is the standard of care, and it was broken. It wasn't achieving what we needed. It was only getting a quarter of the babies back and half the mothers back, which is abysmal. So we interviewed the nurses, and we interviewed a subset of the mothers. And they told us exactly the same thing. They said, we don't know where to go, and we don't know when to go there, because everything's being explained to us in Portuguese, which is the lingua franca of Mozambique. And we don't speak very good Portuguese, we speak our local language. Because the average formal education for women in this part of Mozambique is 2 years. And how much Portuguese are you going to learn in first and second grade? Enough to negotiate in the marketplace with somebody who doesn't speak your local language but speaks Portuguese. That's about it. You're not going to learn, you're not going to understand, you have a virus. You don't feel sick from the virus. This virus might have infected your baby, but we don't know that now because your blood has come into your baby and might test a false positive. And in a month, we'll know because we can do a PCR on your baby, and then we'll find, I mean, that's these incredibly complex concepts that you're trying to explain in a language people don't even understand. So both the mothers and the nurses, especially the nurses, recommended a solution. And the solution I learned from a social worker many years later is called the hot handoff. So in the field of social work, if you have a homeless man and it's in New York City in the dead of winter and he's going to freeze to death, and do you hand him your business card and tell him to take the subway and go to the homeless shelter? Or do you take him to the homeless shelter? The hot handoff in the field of social work is you take him to the homeless shelter. You don't give him a card. It's not passive, it's active. So this was the hot handoff. This is the nurse would, after prophylaxis given to the infant, would walk the mother and the infant over to the EID clinic, early infant diagnosis clinic, counsel them with a community health worker who spoke the local language, register them there now, and then they knew where to come, and they knew why to come, and they knew a month later, and that's what we had. We had an 80% improvement. Now, I can work as a practicing pediatrician till the cows come home, I'm not going to get 80% improvement in my program. This has to be an implementation science initiative. It has to be a structural change in the way we're practicing medicine to be able to get this kind of impact. We also did work on caring for the infants, and our baseline study was absolutely abysmal. If you just look at the one to the right, 61% of HIV-infected children were either dead or lost to follow-up by 24 months. So just abysmal findings. But we published this, even though people told me not to, because this was our baseline. This is where we were going to be working from. This told us how badly off we were, and told us which clinics were the worst off. That's what all those other lines are. So we were able to improve these programs as well. And we looked at pharmacy stockouts, where every time you see a red or black line, you have the near or total absence of the drug. So imagine that you are diagnosed with HIV, but the clinic doesn't have the drugs, or tuberculosis, or you're just coming for your drugs to be renewed and they don't have your drugs. So that's a catastrophic logistics and systems problem that don't be surprised if you have bad outcomes if you don't actually have the drugs available. We did a study in Nigeria led by Daralihu, and that was based on the qualitative work to figure out why we were having bad follow-up rates for women and babies after the mother was diagnosed as HIV infected in care. So sort of like what we faced in Zambia at the beginning, sort of what we faced in Mozambique at the beginning. And we found that the mothers and the infants were being given different appointments on different days in different clinics. We found that many of the clinics did not have CD4 capacity. This is before they were doing viral load as the standard. So that women went to get their CD4 test in one clinic and went to get their clinical care in another. The nurses, we found, were overwhelmed, and very few community health workers were integrated into the community, into the services. And we found that men were often in the way of their spouses and partners coming for care. The men didn't get it. So we did an integrated intervention. And this cost us the ability to tease out which of these four elements made the biggest contribution. And that issue is of enormous interest to Professor Spiegelman. She does a lot of work in trying to tease out in multi-faceted interventions which of those interventions might be contributing the most. So all we can tell you is this package of integrated mother-child care, integrated laboratory and ART care, task shifting from nurses to community health workers to give the nurses more time, and male engagement and outreach into the community to involve men in their spouse's care. And we found that the intervention arm infants were 74% less likely to acquire HIV. So we were able to substantially improve services. In some ways, this is a hybrid between public health clinical trials and implementation science. It's helping you determine what pathway to take for your implementation. The implementation science comes after this stuff, where you now know what to do and you want to expand. So again, the Zoe Morris, we want to make societal impact. And how can implementation science accelerate infectious disease discovery practice? We need excellent research and partnerships. We can reach those in need. That's often what implementation science is doing. Trying to reach those in need, because they're the ones who are not coming to our clinics, not adhering to our medicines. We have to address comorbidities, including mental health comorbidities and the social determinants. Sometimes, if you're asking a poor subsistence farmer to take a day away from his fields and travel a long distance to go to the HIV clinic, he just won't do it. But there are strategies to overcome that have been developed now, including getting one farmer to get the medicines for 5 other farmers. And then they only have to go once every 6 months instead of once a month. Because one person in the group of 6 is getting all the medicines for everybody else. And we have to work on adherence and retention strategies and promulgating best practices as we learn about them. In the US, we have hospitals and health systems, public health departments, something called federally qualified health centers that serve the poor, and you have equivalent units here in Malaysia, I think. And then we need to work with social behavioral scientists, policy experts, communities, policymakers, and advocates. If we don't have these folks on our team, we're not going to be doing effective intervention and implementation science. So I think the care cascade concept helps make implementation science research manageable and applicable both in community and clinical science of healthcare quality. And on that note, I've done the impossible and finished at just 5 minutes after 12. So I think you should clap for that. But I'm happy to take questions because that went a little fast. I usually dwell a bit more and tell more stories, but I'm happy to answer any questions or any comments. I'm sure you've had analogous challenges, and some of what I've told you has reminded you of some of the difficulties we've had in mounting ART, TB programs in Malaysia as well, especially in rural areas. Okay, well, yes, please. And I do have 10 to 15 minutes tomorrow in my session that I have prepared, so a little bit of expansion on the themes. There it works.
Thank you very much. That was really interesting and very practical. My name is Michelle. I'm from Monash University in Melbourne.
Wonderful.
Yesterday we spoke a little bit about equity at the end of the day. How do you build equity into these sorts of interventions and really, reach every member of the population who needs the treatment? Because I think, as you said, often they are the people who are most in need. And I noticed, for example, in 95, it says at the bottom, no discrimination. And you yourself pointed out that perhaps the people who are missing out now are those people who have been difficult to reach. And I'm just wondering, to what degree how do you think those people can be reached? And what ways can implementation science, how can be built into implementation science in the way that we think about planning out these interventions to make sure that those people are reached at the beginning, incorporated into the mainstream early, rather than waiting to see, there's a group here that's dropped off. How can we identify them early and bring them into the program?
That's actually exactly what I'm going to talk about tomorrow in my 15 minutes. So stay tuned. But I will say that we have not gotten very far without substantial community engagement, because the cultural competency of a bunch of Americans trying to work in Africa is minimal. And so having the partners from the communities is essential. And it's also essential not to stop just with the local Nigerian or Zambian or Mozambican doctors, because the doctors themselves have an educational and sort of social gap with the poorest among them. So there's inequities within these countries that are so dramatic. So you have to establish some sort of community advisory process where you're going to get input from stakeholders who are much closer to the people you're trying to serve, from the people themselves. It can be done, and also from practitioners who are caring for those people, not the practitioner at the university hospital in the capital city, but the practitioner, you often a nurse, actually caring for the people who you perceive to be most neglected in the health system. And I don't know, I see a lot of talk about this, but having lived it myself, I can tell you it doesn't work if you do it any other way. It just, you get transient benefits which could just go away. Back to Donna's question earlier about sustainability, and you have to anchor people into their own care. So that's why we did a lot of work with male engagement, because women in rural Mozambique were not empowered. They just were not empowered. The men were making the decisions. And if you didn't get the men supporting the women were not going to come for care. It was that simple. Did I, you know, I just had to look reality in the face, and we had to spend a lot of effort in male engagement. And we created a male champions program where we found the gentleman in the community who was the best farmer, or the best soccer football player, or the best raconteur at the barber shop, or at the shabin, at the bar. People, the men who other men respected. And when we found out who they were, we hired them, trained them, and taught them essentially how to identify the husbands of the pregnant women in the community and talk to those husbands and get those husbands involved in their wife's care with a limited number of points that we were making. We didn't want to overwhelm these people with information, but enough so that they could, and we had very good luck with that program. Very good luck. That's just one of many examples. We'll talk about a couple others tomorrow. Yes?
Hi, Victor here from Mr. Thank you
Oh,
very much.
good.
Very nice talk just now. I hear what you were trying to point out is that I think one of the things is that anthropologists or people actually understanding the people before you actually do anything is important. Right. So when we bring in the people that we the social logists into the system before actually we start anything.
Well, you know, I have had very good luck working with medical anthropologists. I've worked over 30 years with one for 10 years, another for another 10 years, another one for more recent. And I've had very good luck because their insights are more profound than mine. Now, there are two sort of camps of anthropologists. Anthropologists who work in departments of anthropology, who are often taught, like Margaret Mead, sit in the corner of the hut and describe what you see, don't intervene. Versus medical anthropologists who are trained as anthropologists, but they want to work with people like us. They want to work to actually improve programs and to actually guide how those programs can be more effective. So those are interventional anthropologists, activist anthropologists. I want to get something done anthropologists, not just observe. So it's not every anthropologist who has an instinct for this, but there are enough of them around that I think we can recruit them early on. And they have been taught in the qualitative methods of observation, communication, and essentially they're some of the more patient researchers. I'm a very impatient person. You ask me to be an anthropologist and work out all the details, I would rather hire one because she's going to do better than I'm going to do. So at the end of the day, we've had very, very good luck involving them in our work, and they have made an enormous difference in some of the work that I've just showed you, for example. And I think, you know, there's a short supply. We don't have enough medical anthropologists. We need to be training more. And it's also very helpful when the medical anthropologists want to do a little extra training and actually train in public health as well. Because 2 out of 3 of the medical anthropologists that I've worked with decided to go back to school to study public health so they could be that much more effective at applying their discipline to health medicine and public health. But you're right, getting them involved right from the start, very wise. Unfortunately, I have sometimes had to go to them out of desperation because my programs didn't work. I wished I'd gone to them earlier. All right, well, enjoy your lunch. Thank you.